I'm Dr. Rebecca Bowers, and in this video I will be discussing trigger points and how to treat them using manual techniques. The information in this video is based on this book and my clinical experience palpating and treating trigger points. There are actually 2 volumes and they have a lot more information, including treatment methods involving injections and vapocoolant sprays. A myofascial trigger point is a small hypersensitive spot in a skeletal muscle or its fascia, usually within a taut ropey band, that when active causes referred pain and/or other manifestations, including autonomic phenomena. Often trigger points prevent full lengthening of the muscle, weaken the max contractile force of the muscle, depress deep tendon reflexes, and patients may complain of a feeling of stiffness in the muscle that is worse after being inactive. Normal muscles do not contain trigger points. These are a type of somatic dysfunction and are often caused by other somatic dysfunction. Pushing on a trigger point causes pain at the site as well as triggers a reflex mechanism that manifests other signs and/or symptoms at distant sites. The distant region where the trigger point's referred phenomena occurs is called its reference zone, shown here in red. The reference zone for a given point is consistent from person to person. There are charts that show the most common trigger points, but muscles can get other trigger points, each with their own reference zone. Here are the locations of some common scalene trigger points and their referred pain reference zones. The solid red areas are called the essential pain zone, and the red dots represent the spillover pain zone that is less often present. It's important to note that sometimes the reference zone is located around the trigger point, like with these middle deltoid points on the right. So when pushing on a point to see if it refers pain, make sure to ask the patient something like, "Does it hurt only where I pressed, or does it hurt around it or somewhere else too?" If it hurts at a spot other than exactly where you are pressing, then it is likely to be a trigger point. Some of the most common non-pain referred phenomena are spasm, vasoconstriction or dilation, sweating, hypersecretion of glands, and pilomotor response, usually occurring in the reference zone. While most trigger points seem to predominantly affect musculoskeletal function, there are trigger points that affect the functioning of organs. One such somatovisceral trigger point is located in the right pectoralis major muscle and has been shown to have a causative relationship with supraventricular tachycardic arrhythmias. Trigger points are not all or nothing, on or off. Once they develop in a strained or stressed muscle, they can be affected by multiple stressors. Even the pain they often generate can further stimulate them and cause them to become more active. This is why sometimes someone with a trigger point will only have pain at the spot when it is being pushed on, while a more active point will have pain at the spot when it's being pushed on, as well as in some or all of the reference zone. And when the point is really active, then pain can occur even when the point is not being pushed on, when the patient is at rest, or when the muscle is being passively or actively stretched. Regardless of how severe and where the pain is, there are characteristic palpable findings that let the examiner know that they are dealing with a trigger point. Learning to palpate the characteristic tissue texture abnormalities of different types of dysfunctional points will allow you to feel confident that you are applying the correct type of technique to the correct type of dysfunctional point. For more information on distinguishing between common dysfunctional points, watch my What's the Point video. So what characteristic findings suggest a trigger point dysfunction? The point itself feels to me like a flattened fusiform bulge on a taut ropey band of muscle that runs parallel to the muscle fibers. I liken it to a ravioli on a tight rope. Pushing on the trigger point causes pain, often out of proportion to the amount of force being applied. It may or may not cause pain elsewhere. Many texts discuss the twitch response that occurs when an examiner applies a snapping force at the point in a manner perpendicular to the muscle fibers, but I find it is an unnecessary bother to try to elicit this. The reference zone may have some of the previously mentioned referred phenomena, but what I most consistently notice is that it has a characteristic shrink-wrapped feel tissue texture abnormality, where the soft tissues feel shrink-wrapped or compressed against their deeper soft tissue structures. Manual treatment of a trigger point is typically done using a type of soft tissue technique involving deep pressure. I have found that you don't have to press deeply if you allow yourself to be guided by the changing response of the tissue texture abnormality at the reference zone. You only have to press in as hard as you need until you feel the shrink wrap start to relax, and eventually it will fade away. Usually this takes about 20 seconds. If it seems to be taking longer, it might be a satellite trigger point. More to come on that in a moment. Remember that trigger points occur because a muscle is overstressed. Most always there is a dysfunctional or structural issue, and if the causative issue is not corrected, these trigger points will soon reactivate. Make sure you address the underlying issue to the best of your ability. This may mean treating other somatic dysfunction, optimizing ergonomics, prescribing durable medical equipment that supports posture, or referring someone for joint injections or surgery. As with any medical procedure, one must consider the known contraindications as well as the clinical scenario of their unique patient's case. Most of these are not a concern when applying gentle to moderate pressure on a trigger point. Let's watch a video of me finding and treating a trigger point.
Let's say you're examining the cranium of your patient, and as you're palpating, you come across an area that feels like it's shrink wrapped, which in his case is right around through here. This feels like the tissues are kind of compressed down in like shrink wrap. All right, so to me, that's what a reference zone feels like for a trigger point. It's the characteristic tissue texture abnormality I feel. Now, if I had it memorized, I could know where to look, or if I had a chart in front of me, those can be handy. But this one is going to be related to the masseters, the more superior aspect. I like to monitor that tissue texture abnormality and then go looking in the muscle for the trigger point. So he's got the trigger point right about here. How do I know? Well, one, there's this taut line of ropey muscle tissue. It's nice and parallel with the other strands, but the other strands aren't so tight, and we have this one taut one. Within, on that taut, tight rope, is a nice little squishy thing that feels kind of like a ravioli. The other thing that makes me think that this is the point related to where my left hand is monitoring the shrink wrap is when I first come in contact with the area, very briefly it tightens, which tends to happen with autonomically linked dysfunctions. They just kind of like, they're on the same circuit and they go, ah, when you interact with something that's related to them. But as I push in a little bit more to the ravioli, that shrink wrap feel starts to disappear. So that's really important for me as far as treating. I allow that shrink wrap feel to guide my treatment. So I only have to push into the ravioli and do that soft tissue inhibition as hard and as long as the shrink wrap is guiding me and letting me know that it needs to be.
As I mentioned before, a satellite trigger point does not easily treat out. That is because it resides within the reference zone of another trigger point, and the referred phenomena of that other trigger point stresses the satellite point. When a trigger point is simply caused by the overload of mechanical strain, it is referred to as a primary trigger point. But trigger points can cause other trigger points because of their effects on soft tissues and the function of muscles. For example, let's say someone develops a trigger point in their upper trapezius. Within its reference zone, there resides the potential for other trigger points: splenius capitis, the upper part of the sternocleidomastoid, the suboccipitals, and the temporalis. Due to the stress caused by the shrink-wrap tissue texture abnormality in the reference zone, one or more of these points could be activated. They would be satellite trigger points. They each have their own reference zones and could in turn activate more points. If you are dealing with a satellite trigger point, the trigger point will have the usual ravioli on a tightrope feel, but also over and around it will be the shrink-wrap feel. These trigger point chains can become quite complicated and feed back on each other, and finding the primary trigger point is essential for complete and lasting resolution of all the satellites downstream. Having charts readily available will assist you in making sense of the location and shape of the various reference zones so you can identify the location of the corresponding point. I have made this video as a resource for other physicians and body workers. Do not attempt to perform any manual techniques unless you are a physician or body worker or a student under proper supervision.